A case of ahi basking in the sun, scombroid-associated lactic acidosis. Scombroid poisoning is a rare condition, however, it is present in Hawaii. Our learning objectives are to appreciate the natural history and pathophysiology of scombroid toxicity, to identify its clinical symptoms, to recognize scombroid poisoning as a potential rare disease entity, and to understand the public health significance of reporting scombroid poisoning. A 54-year-old woman without previous past medical history of allergies, cardiac, or vascular diseases presented to the emergency department 3 hours after the onset of flushing, epigastric pain, chest pain, dizziness, and lightheadedness after eating smoked ahi that was prepared by a friend. She checked her blood pressure at home and noted that her systolic blood pressure was in the 80s. She endorsed flushing, redness of her eyes, chills, abdominal pain that had migrated to her chest, and nausea. No other family members who ate the same fish had similar symptoms. On examination, she had a temperature of 36.8, a heart rate of 120, arterial systemic hypotension, a respiratory rate of 22, with an oxygen saturation of 98% on room air. Her skin was warm to touch, and she had diffuse flushing of her face, her trunk, her extremities, and her back. The patient was treated in the emergency department for infectious hypersensitivity and anaphylactic etiologies with 3.5 liters of normal saline, Zofran, ceftriaxone, Benadryl, methylprednisolone, and famotidine. Her lab tests revealed a lactic acid of 4.8 on admission, which subsequently rose to 5.5. Myocardial necrosis markers were not initially elevated. Her blood pressure then improved to 114/51. On the second day of hospitalization, her troponin I was elevated to 0.22 in the absence of any cardiac findings and subsequently downtrended to 0.12. Given the clinical history and presentation, the patient was diagnosed with scombroid poisoning. Following fluid resuscitation, her lactic acid elevation resolved, and she had returned to her baseline function. This case was promptly reported to the State of Hawaii Department of Health Disease Outbreak and Control Division. Scombroid poisoning occurs via amino acid conversion by bacterial enzymes through the conversion of histidine to histamine. The poisoning occurs due to the inadequate cooling and poor preservation of the fish. The high content of histidine in the tissues is typical to species such as mackerel and tuna. Given that the symptoms of scombroid poisoning are similar to that of IgE-mediated allergy, it is often misdiagnosed and underreported. Our differential had included scombroid poisoning, ciguatera toxin poisoning, allergic anaphylaxis, angioedema, urticaria, alcohol ingestion, drug ingestion, carcinoid syndrome, neuroendocrine syndrome, and systemic mastocytosis. In addition, this presentation is variable and can include vascular compromise, bronchospasm, arrhythmias, cyanosis, and Clunas syndrome. A major limitation of this case is that we made a clinical diagnosis without attaining histamine or tryptase levels. We urge clinicians to remain vigilant about scombroid poisoning and its variable presentations. An accurate and prompt diagnosis can prevent widespread disease and can have a significant public health impact. Thank you.